The objectives of the talk today is to talk about ICDs. I presume everybody knows what one is. We heard about them this morning from Dr. Ackerman's talk. What it is, why consider it, what are the current recommendations for ICD placement, what's the upside of an ICD, what are the risks of ICD placement, and long-term considerations of an ICD. Well, what's the problem? I think everybody here knows what the problem is that some patients are at risk or have had a sudden cardiac event. Studies have shown that outcomes after cardiac arrest outside the hospital are improved with good CPR and with the shortest time to return to normal cardiac rhythm. So the faster we can defibrillate somebody who's in an abnormal rhythm, then the better the outcome. And anecdotally, I don't have data, but anecdotally, in my experience, the widespread availability of AEDs have really changed the outcome for patients, both in survival and in neurologic outcome, that we are seeing so much better neurologic outcome after events because of quick time to defibrillation. So if you take quick time to defibrillation as one of the most important factors, then that gets us, well, the quickest time to defibrillation is not to wait for one, but to have one with you. So it all sounds like a great idea. The upside of an ICD. With an ICD, the device immediately recognizes a life-threatening arrhythmia, and it delivers a shock, a potentially life-saving shock. You do not have to wait for someone to obtain an AED or for EMS to arrive. It presumably would improve survival and improve neurologic outcomes. I don't have any conflicts. I did get this slide from one of our reps from Medtronic to just show the different sizes ICDs to say where they've come from. That I think the first one was in 1989. It was a very big device that generally went in the abdomen, and then over the years the device has gotten smaller to its current size today, and that makes a big difference when we talk about availability for all patients, no matter what size. And this is all the different companies. They come in different sizes and shapes, but they all do basically the same thing. The newest device is the subcutaneous ICD over there with a hand, and that may provide some benefits for some patients in terms of when we talk about downsides. The subcutaneous ICD does not have a lead to the heart. So ICDs are made up of a lead that goes into the heart or on the outside of the heart and then connected to a device. The subcutaneous ICD has a lead as well, but it's all subcutaneous. It's all right underneath the skin, so you don't have to actually attach it to the heart, which could have some advantages. In terms of what are the good sides of ICDs, I wanted to make sure to talk about pacemaking, because when we think about ICDs, we think about only the shocks that they deliver. But Susan Etheridge mentioned it earlier, is that current devices, all ICDs, have pacemaker functions. So the pacemaker function keeps the heart from going too slow, especially when the patient is taking beta blocker medications. So you might have a slow heart rate based on your underlying disease, and you might have a slow heart rate based on beta blocker. And in some patients with long QT, the pacing can smooth out the heart rhythm and decrease the number of events. I don't have specific data to say what percentage of patients that helps with. There's a lot of anecdotal data, actually. Like a parent of one of my patients had a pacemaker before they even realized what long QT syndrome was, and she never had an event with 12 years of just pacing alone. So the decision of, do you need a pacemaker, do you need an ICD, the pacing function could really help some patients. And then, of course, what we focus on is the shocking function of an ICD. So this is a printout from a device. The top lead is the atrial lead, and the bottom lead is the ventricular lead. And the ones on the bottom tells us what the machine is seeing in terms of the milliseconds, how fast it's going, and if it's going in the upper or lower chamber or not. And so you can see that the lower chamber is going a lot faster than the upper chamber. And then at the end of that, there's a deflection, and that's when the shock is delivered, and then it's a slower heart rate after that. The implant techniques are varied. If you're a smaller size patient, and the smaller size is depending on which institutions you're at. Generally 10 to 20 kilos, most likely recommended for an epicardial system, which means outside the heart. This is a picture I got from the internet of just a sternotomy, so it looks like anybody who's had heart surgery basically to open the sternum, but then you don't have surgery on the heart, you just put a lead or a patch on the outside of the heart, and then in this case the device itself is in the abdomen. The size can be debatable depending on what you think is the risk-benefit for that individual patient. And then the standard approach is the endocardial, or inside the heart wires pass through veins, and this came from a paper where I was senior author on, where we were looking at different implant techniques, which I will show you some pictures later in the talk. But this is a standard approach. It's called the infraclavicular approach. The incision is up here in the left upper chest, and that's the X-ray picture of how the device and how the lead looks inside the heart. So there are guidelines for ICD implantation, and these guidelines change every 4 to 5 years, where physicians, experts in the field get together and sit down and say, what is the current evidence of placing a device? What are the current reasons that a device should be placed? And then within that, then each physician will, when you go to them and you say, should I have a device? They should look at these recommendations and say, do you fit the Class 1 recommendations? Which Class 1 recommendations would be, yes, you should have a device. So when I looked up the guidelines, 2008 guidelines, the ICD implantation is indicated in the survival of cardiac arrest after evaluation to define the cause of the event and to exclude any reversible causes. Another one, ICD implantation is reasonable to reduce sudden cardiac death in patients with long QT syndrome who are experiencing syncope and RVT while receiving beta blockers. So you can go to the website and find the exact recommendations and see if you or your loved one fits into those recommendations. But there are some blurred guidelines where there's a lot of judgment and patient and physician discussions that can happen because, as in this slide, which I think Susan's on, right? No, Tess is on. This is a multi-center study of the effectiveness of implantable cardiac defibrillators in children and young adults with heart disease. And what this graph shows us is the year on the bottom, and then percentage of implants, where the darker color is for secondary implants, and the other color is for primary implants. So what's the difference? Secondary is if you've already had a cardiac arrest and we're going to give you a device. I think that's probably the easiest group of patients to decide if they need a device, although with Dr. Ackerman's new data and saying, well, perhaps if you had an event that you were untreated, perhaps you should be treated with medications and then consider an ICD. So I think there's even some discussion with that. But the hardest group that I feel is the group of primary implants, which is we are looking at you and we are saying you are at high risk for sudden death, so therefore we're recommending an ICD. Now, if your QTCs are greater than 500 and you fit into one of the categories Dr. Ackerman talked to, then it's a little bit easier to say you need a device. But I have to say, in my population of patients, most patients are not like that. Most patients are more in the gray area. They have QTCs of 480. They might have had one syncopal event. There's things that much more of a gray area, and we want to say, are the risk of an ICD worth the downsides of an ICD? If you look at a lot of studies, what's the rate of appropriate shock, meaning that you had a life-threatening arrhythmia and had a shock? And in several of these studies, they got the range of about 25 to 28% receive an appropriate shock during follow-up period of the study. So that's not forever for the study. A lot of the studies have follow-ups plus or minus 5 to 10 years or through their first generator, and that's the approximate appropriate shock rate that we have in that population. One of these studies, I think, had a much higher percentage shock rate. And if you look at, there's several papers that showed this type of graph. It's years compared to discharge-free survival. And it kind of makes sense that if you've got the device because we think you're at risk, you have a less chance of having a shock required. That's because we don't know, if we think we're at risk, we're not sure if you're going to be at risk next year or in 10 years from now. So during follow-up of the study, you have a discharge-free percentage is better if you have your device because you as primary implant versus if you've already have an event, you're likely to have another one. And so that group of patients we think are good for having an ICD. I was just looking at the most recent literature, and this came out of Dr. Ackerman's lab, the implantable cardioverter defibrillator therapy just in that group of patients with congenital long QT syndrome, and what is their experience with ICDs in that population of patients, which sometimes we branch out to say, does that equal to CBBT or does that equal to ARVC? And I think we can't generalize as much, but we do take a lot of information from looking at single groups. And their findings were that 51 long QT patients with an ICD compared to 408 long QT patients without an ICD. 24% of patients experienced appropriate shock, so that's in the same range of the other data that I presented, and 29% experienced an inappropriate shock. None of the 408 non-ICD patients had long QT-related deaths. So that's our current treatment in terms of what chance, if you get an ICD, what's the chance that you're going to have an appropriate versus inappropriate shock. Now those two things don't equal each other, right? And even an appropriate shock, sometimes we equate appropriate shock with saving a life. And I think that's the case sometimes, but it's not always the case. And I don't think it equals 24, there's more inappropriate shocks, but we're saying, well, that's a liability that perhaps we can live with because we've saved however many people's lives. And it's hard to balance those things in terms of the risk to the patient. So, just interesting, I wrote conclusions here. Oh, conclusions from his study. Vast majority of long QT syndrome patients can be treated without an ICD. Potentially life-saving therapies occurred in 5 to 6% per year. Shocks occurred in patients with ICD for secondary prevention and with a QTC greater than 500. And ICD frequency greatest in long QT3 patients, but the greatest save rate was in long QT2 women. I think you've heard that from the prior speakers. And there was a similar inappropriate shock rate. This is a study, just came out in American Journal of Cardiology in this year, that looked at CPVT patients. Now, that's a smaller group of patients than long QT1, so when you look at data, you have to be careful. It's not like this is on 1,000 patients. It was on a relatively small group of patients. But I thought the graph was quite striking because what it talks about is years after diagnosis and percent survival. And the top two lines that are straight across at 100% is that if you're an asymptomatic patient without an ICD, or if you're a symptomatic patient with an ICD, you had 100% survival. But if you continue to have symptoms, deciding on or off treatment, if you continue to have symptoms but said you didn't want an ICD, then your survival was much lower and did drop off over years after the diagnosis was made. So in this group of patients, which I'll talk about later, probably has a high risk of inappropriate shock rates, probably has a high risk of shock rates, and the shock doesn't necessarily get the patient out of the rhythm, where we're considering whether or not CPVT patients benefit from a device or not. This graph would say symptomatic patients, despite treatment, really do benefit from having an ICD. Okay, well now I get the fun, not so fun, topic of downsides to an ICD. I think, like I said earlier at lunch, which anytime we do something, we should talk about the risk and benefits to that individual patient with the knowledge that we have at the time. And I think a problem with going through this list is that it ends up being a pretty big list, and anecdotally, as a physician, I probably have a scary story for every one of those. But the risk of these are very small. And the question is when I talk to patients, I say that, if I tell you the risk is 1 in 100, but you're that one, it matters to you what you've gone through. So we'll just walk through these one by one. First of all, there's the risk during implant, and I think in general these risks are really small. That you have the risk of anesthesia, you have a risk of infection. Risk of lead dislodgement, that means if a lead moves. Risk of pneumorhemothorax, that means some blood or air in between your rib and your lungs. Risk of testing the shocking portion, that means being put into abnormal rhythm and having the device shock the heart back to normal, and then immediate afterwards pain at the site. So when we implant a device, we talk to the patient about all these downsides, and they sign the consent form. And in general, at an institution that implant devices, I think we do minimize all these risks for the day of implant. I think the risk of the shocking portion of the device, I think that's higher in patients who have like decreased heart muscle function. But in our patients who are primary electrical disease, once you shock the heart back to normal rhythm, then the heart works normally. So some of those issues in a different population, we worry more about them than in the primary electrical population. And what about lead issues? I think the leads are the weakest link in the whole system, and they have risk of lead dislodgement, lead fracture, lead insulation break. You get some scarring at the lead to heart interface so that the device can't see the normal heart rhythm as well. And when you place a lead through the heart, you can potentially damage the heart valve that you went through. That doesn't, I think I've seen that once in 12 years. You can have poor sensing of your normal rhythm. You can have inability to pace, or you can have pacing diaphragm. So that's quite a long list of lead issues, and I think the companies are trying their best to address all the lead issues, and there's been some lead recalls, especially in the smaller leads. So I primarily take care of pediatric patients. We try to use smaller things, smaller leads, and some of the smaller leads have had more of the problems with leads themselves. This is an example of a lead dislodgement. This patient happened to have congenital heart disease. And that I had arrows on where the atrial lead is and where the ventricular ICD lead is. And then this one's not quite fair because the patient had a catheterization, and the intervention that was done, they ended up putting a lot of different catheters and such into the heart, and the leads got dislodged. So you can see where the ICD lead is pulled back into the atrium. And you can't really see the atrial lead as much, but it shifted down a lot more. So that was an iatrogenic, meaning the physician who was doing the catheterization accidentally, when he's putting other catheters into the heart, causes tension and actually pulled those leads out. Now, if you don't have congenital heart disease, then obviously, as long as you keep people out of your heart, you'll be okay. But a lot of people ask me, well, how about exercise right after you have an ICD implant? And I don't think there's a whole lot of data to say what are the risks of lead dislodgements. The lead dislodgements tend to happen like in the first month after implant, and once they're in and they're chronic, they tend not to move, so it shouldn't be a long-term issue. It's more the time of implant. Inappropriate shocks, I think we don't pay as much attention to because we're like, okay, but if they have appropriate shocks and it saves a life, then inappropriate shocks we just have to deal with. But I think as physicians, it's our job to minimize inappropriate shocks as much as possible, because they cause harm, not necessarily to the heart. I've actually never seen an inappropriate shock hurt the heart, but it does affect the patient and the patient's feeling about their device and their quality of life. This is an example of a lead that was starting to fracture but didn't quite fracture. So the upper strip's called the atrial lead, and that's what you're seeing is a nice regular rhythm. And the lower chamber ventricular lead, you see how there's just a lot of different electrical signals on it. It's not regular. The reason why it's not regular is that it's starting to fracture, so you just get some electrical noise on the device. If you have electrical noise on the device doesn't know it's noise, and it calls it that it's having a dysrhythmia and can give an inappropriate shock for that. The other reason for inappropriate shocks in our pediatric population is the heart rates tend to be higher in young patients, and so if you can naturally get your heart rate up higher past your level of what the device is set at, then you can get an inappropriate shock from having a normal fast heart rhythm. On also some of our diseases, as we heard earlier, as well as lower chamber arrhythmias, you can have upper chamber arrhythmias, and the upper chamber arrhythmias then cause a fast heart rate, and that can get what's called an inappropriate shock. And then this is what I alluded to earlier about ineffective shocks. And I think, I know one of my colleagues had presented at the Heart Rhythm Society meeting, but it has not yet been published, looking at data from CPVT patients and saying what percentage of time does a shock in a CPVT patient actually cure the patient and get the rhythm back into a normal rhythm. And this is an example where, in fact, the shock did not help the patient. Again, we're getting used to looking at these printouts. The upper chamber is going fast as well. It looks kind of fast and irregular. The lower chamber says the ventricular lead. This one is a relatively fast and more regular rhythm, but it meets ICD criteria. It gets ready, it gives a shock, and then right after a shock, you can see that the rhythm didn't slow down. So in this particular patient, they had passed out and they had a seizure and received multiple shocks. And this problem with this disease and other disease, if you get a shock, you have increased adrenaline. The increased adrenaline can help put your heart back into that same heart rhythm or make a currently fast heart rhythm even faster or more dangerous. So this is something we called ICD storm, and it does not happen that frequently, but it is most concerning, I think, in patients with CPVT, but also I think is reported in long QT patients, and it's of significant concern to our patients. What about device recalls? Devices are mechanical and they can have issues. Mostly they are warnings and not full recalls, because when people think of a recall, it means this device has to come out. But anytime you're talking about a patient and implanted material, you have to look at the risk and benefits of that implanted material and say, okay, what are the risks of anesthesia? What are the risks of extracting this device? Like Tess had said, that it's high risk to extract devices. So we have to balance those risks of leaving it in versus the risk of taking it out. Most of the time with the warnings, the event rate is extremely low. And most of the time, it's that the device needs more monitoring. Sometimes, depending on the patient, like if you're completely pacemaker dependent, then sometimes we'd say, I don't think that risk is worth it. I want to go in and change the device. And thankfully, the chance of this happening is small. I'd say over the last 10 years, with a lot of that's happened with devices and such, the companies have been very transparent with transmitting information to physicians and saying that we've seen this happen in whatever percentage of our devices, and then we try to transmit that information to the patient to say, well, we're going to be watching your device more closely. Other issues, infections. Infections are reported in about 0.5% to 6% of patients. In transvenous systems, the estimate that I found was like 1.2 to 1.8%. Infections are not good if the device gets infected. The device has to come out, which is a high-risk issue, and then the patient has what we call morbidity, which is problems from it, meaning that you need antibiotics for about 6 to 8 weeks. So we take infections very, very seriously. The chance of infection is related to most infections occur within 90 days of intervention. Device replacement is higher risk of infection than your new implant, and we think that's because of some of the specifics of the procedure itself, how the body heals devices. They kind of solidify this capsule over it. So when you go and change a generator, the capsule's still there, and there's not good blood flow and stuff to the area. We think that's an issue why there's more infections with generator changes. And then if you have more complex devices, if you have more leads, for some reason those patients are at more higher risk. And then the need for re-intervention. This is not insignificant in our young patients. If you have an ICD, no matter what age, I think one of my youngest patients is about 4 years old with an ICD. But if you get one at 10, if you get one at 15, you're hopefully have a long life ahead of you because of the treatments, because you've been identified and you've had treatments and you've found the proper therapies. then what an ICD does is that once you have an ICD, you are going to need another surgery and another procedure to change the generator out when the battery is low, when the leads stop working, and that might be more of an issue with growth. So if you have a patient with transvenous system at age 10 and they double their size when they're teenagers, the patient grows and the lead doesn't. So then you go back to the lead issue and have to talk about a risk of lead extraction. In one study, we found that 14 to 25% of patients required a lead revision or extraction replacement in 5 to 7 year time period. And this is one that I've been focused on in the last 5 to 7 years since I've been in Denver, about the cosmetic outcome. And that really depends on the implant technique. And I think there's a bias that most implanters are not necessarily thinking about cosmetic outcome, because we're talking about life and death. And so we're focusing on that this device can save you. But Dr. Ackerman's next talk is going to talk about how do you live with this disease? How do you live with an ICD? What's your body image? How can we make living with this disease or living with an ICD better? And so cosmetic may be very important to the patient, especially if they're younger, getting a device. And so, so there are these various techniques to placing an ICD. It does not have to be in the standard left chest location. So there's a couple under the arm techniques. They're called axillary techniques. In this one, this is a young lady. It's a vertical incision. You can just barely see it above her jug bra that she's wearing. And then on the chest x-ray, it looks exactly like the prior chest x-ray I showed. So the device has an incision from here to here, and everything gets slipped in, and it's there, it works, but you don't see the device, and you don't see the scar when you're wearing most clothes. The second under the arm technique, which is the one that I have been using, is a slightly different one. We do a small incision in the standard location just to place the leads, and then we tunnel the leads underneath the arm, and then the device is actually sitting right in the axilla. We call it right in the armpit. The reason why we use this cosmetically, I think, is slightly inferior to the first technique in the sense that there's still an incision on your chest wall. But I think long term, I like this technique for a couple of reasons. Is that when we put them in, we always have to think about what if they're going to come out, and if the leads have a problem or the device has a problem, how is it easiest to get it out? And this technique is pretty straightforward to get out because their leads are implanted right here. That's where we can extract it. You don't have a long area in which to try to add more area for extraction. And the device in the armpit is very easy for generator changes, no matter what changes in your body habitus. Like if you put an ICD in a 5-year-old and then at age 10 they have really increased their weight, they have a lot more subcutaneous tissue and stuff to get to. Well, this technique, the device is right there and easy to go and have a generator change from. And then one I have not used is the submammary technique, but it's been published as well, is that you try to hide the device underneath breast tissue. And that's another, all going towards what is a better cosmetic device, cosmetic outcome, as long as it does not hurt, as long as it does not add excess risk to the patient, either short or long term. And that leads right into, well, what's the psychologic impact from an ICD? Well, we think that there's psychologic benefit because there should be some perception of greater security because you have this device with you, and it's okay to be by yourself, and it's okay to let your child, go to Europe. It's okay to let them out of your sight because they are protected, because you're not always going to be with them or your loved one. But there's a psychological risk as well. There's specific ICD fears. There's symptoms of anxiety in about 13 to 38% of adults that are studied. And there's depressive symptoms in about 24 to 33%, and that's kind of similar to other cardiac populations. And the risk of psychological difficulties, and most of these studies have been done in adults and not in children, that younger patients, what they define as less than age 50, multiple ICD discharges. I don't think that appropriate or inappropriate, it didn't matter, I think. Female gender, psychological difficulties prior to your ICD, low social support, poor understanding of the conditions and device, and more severe medical conditions all led to the higher psychological difficulties in patients with an ICD. Well, what about potential risk in younger patients? Some studies report the higher risk of appropriate and inappropriate shocks compared to the adults. There's a lot of things that are not necessarily studied, like changes in body image, the disruption in lifestyle, the distressing social comparisons about having a scar, having an ICD when other people do not have them, having to explain what it is, and also adjusting to the risk of a potentially life-threatening arrhythmia. There are some social interventions that have been done in adults, and I know one of my colleagues at Stanford is working on some interventions in children, where there's cognitive behavioral therapy, there's cardiac education and rehab approaches, and like I said, there's studies in adults and not a whole lot of studies in children, but we're working on how to address these issues and minimize them. I myself am doing a quality of life study in young patients with an ICD or a pacemaker in the axillary versus standard location to see if location alone might make a difference for these patients. So an ICD or no? Well, it depends on your diagnosis. It depends on symptoms. It depends on if one has failed medical therapies or not. And it really depends on the patient's age and size. And basically, you need to talk with your physician about what the risks and benefits are for your particular situation. And it's a balance. It's a balance, pros, it's always with you. It can work immediately. And we as physicians really do believe that ICDs save lives. And that's been shown in literature. But there are a lot of cons which we talk through, and those have to be balanced. And they're not one-for-one decisions. You can't say, just because the list might be longer on the con side, the pros of saving a life, you can't equal that. There's a couple other questions that I want to leave you with I don't have answers to, but are ICDs better than having an AED? So after discussions with Dr. Ackerman about a year ago, I started also giving my suggesting that our patients, recommending our patients with newly diagnosed arrhythmic diseases have AEDs at home. But are they enough? Is an AED equal to an ICD? And I don't think there are any specific studies. I have not had any patient with their AED need to use it, thank goodness. It sounds like Dr. Ackerman only had one patient which required it. So I think the biggest issue is just having one with you all the time, and how does that work when your children are not with you, when they're in sleepovers, when there are other things, as an AED versus an internal ICD. I've been asked this question a lot, and I think it's a very hard answer, which is, okay, you tell me that I can't exercise, so what if I put an ICD in? Does that allow me to exercise? And does that give me complete freedom to do anything I want? And number two is, do I need to take beta blocker? Can I have an ICD and not take a beta blocker? And I think that's when the discussions from Dr. Ackerman was saying, well, this is approaching, there are two different ways to treat this disease. One is protecting that fire and protecting you so you don't go into it. And then the ICD is an emergency treatment of it. So I don't think it's not like you can have one and not the other. Have an ICD but not take a beta blocker. And with that, I will close. Thank you.